Hello, good morning. In emergency cases in child and adolescent mental health, I'm going to be talking about cases presenting with anxiety. So, mood disorders and for any threat coming from outside, any kind of the these are the it's an adaptive emotion that allows us to eliminate from the risks coming from outside. But normal anxiety does not uh, take for a long time, but if the anxiety occurs when there is no dangerous situation, then it is disturbing this situation. And emergency visits in the pre-pandemic period, I mean, we had this pandemic period and they couldn't go to school and their social lives were affected, and the presentation will be divided into two, like pre-pandemic period and post-pandemic. Between 2007 and 2016, in this nearly a decade period, there was a 100% increase in the cases who applied to the emergency department with anxiety. And there are many reasons for this increase. If we compare these 2 years, it, there was a 3.85-fold increase in annual number of patients admitted to emergency consultations. But in 2017, 34% it's like 7 times more. But in the emergency departments, the reference, the referral chain in emergency, generally parents directly applied, but the triage structure has been changed. And another study comparing pediatric emergency department admissions over a 10-year period before the pandemic and the number of mental health symptom visits compared to a 9% increase, but the others were 47%. So what happened during pandemic? There, until August and September, people were isolated and there was quarantine. They couldn't leave their homes. But because if we look at 1 year period, the applications to the emergency was like 100% increase. And the Canadian study found that one of the biggest increase in child and adolescent emergency increased like 74%. Another meta-analysis found that the prevalence of anxiety in children and adolescents increased in prevalence. And the anxiety, there are some psychological, are there always psychological reasons underlying? It could be medical conditions, substance use disorder, withdrawal, panic disorder, generalized anxiety disorder, obsessive compulsive disorder, acute stress disorder, PTSD, or psychological disorders can be the symptoms of anxiety. And there are some studies done in our country as well. But for pediatricians, there might be false preconception, maybe. There are many patients having anxiety symptoms, but many few patients are consulted in pediatric psychiatry. So while studying this or while recognizing this, In order to prevent the recurrent applications, psychoeducation should be given, or of course, there are medical conditions that can be the reasons of anxiety. It can be arrhythmia, hypertension, mitral valve prolapses, and congestive heart failure, epilepsy, migraine, or hyperthyroidism, or neoplastically carcinoid syndrome, acute intermittent porphyria, and anemia. They could be the reasons, and all of them can come to the emergency ward for the reason of anxiety. And but of course, we do not, or they do not call for a psychiatrist for the applicant, the patient who comes to the emergency ward. Generally, neurologically examined, and if necessary, MR should be taken, and then they should be evaluated. If there is an atypical age or sudden onset, or if there is and fever, malaise, or confusion accompanying that, of course, physical examination should be done. And use of medication or substance use disorder, or the abuse of stimulants, marijuana or hallucinogen abuse, they all can cause anxiety, or benzodiazepines and antipsychotic medications, or sometimes the patient does not tell them, but we should be asking them. It could be akathisia or anticholinergic medications might come to us as the anxiety symptoms. And panic disorder in emergency ward, these are the most common psychiatric disorders that we saw. And some emergency ward studies show that recurrent applications increased up to 33%. In fact, it shows that we are not referring the patients properly. That's why they repeatedly come to the emergency wards. There are some palpitation or accelerated heart rate, chest pain, or dizziness, sweating, trembling, or chills or hot flushes, nausea. It can be first attack, maybe in the young people, or fear of dying, or fear of loss of control, or going crazy. They could be the other reasons or symptoms. So if there is a stressor in the patient, or is there a history of in the family for anxiety? And chest pain is one of the symptoms frequently seen, and it is a symptom that makes us to look into that. But 0 to 10% of the ranges have been reported with chest pain that patients present cardiac disease. But so it's very low rate. Generally, it can be asthma or pneumonia or any other reasons it could be. And in another study, the rate of anxiety disorder to be 81%, frequency of panic disorder to be 28%. So the patients coming to emergency department with anxiety, most of them are not referred properly. So they have to come over and over again. Generalized anxiety disorder, it's a more chronic disorder. And it's not as frequent. But if there is a stressor, anything increasing anxiety, for example, the child or the adolescent has experienced an acute situation, we can see that. And the discriminative diagnosis can be asking about period or the length of the disorder. An obsessive compulsive disorder, so as we all know, OCD has recurring thoughts, ritual compulsion. It has these kinds of symptoms. And it could be an anxiety caused by intense obsession or some in the sexual and religious obsessions. It can also go with aggression or the feeling of guilt. This could be also seen. What we have seen with anxiety in the patients, we have to question the suicidality because if there is intense anxiety, they might not deal with it, and then they might attempt to commit suicide. Acute stress disorder can occur immediately after a traumatic event within around 1 month. This could be dissociative symptoms, avoidance symptoms, arousal symptoms. Unfortunately, some people can lead to post-traumatic stress disorder, and there can be sleep disorders or avoidance, and with intense anxiety, they can come to the emergency department, and we have to question the family, and maybe the child has anxiety to talk to the parents. So we have to, they have to be evaluated when they come to the emergency ward. PTSD, it's the long-term situation of ACD, and they cannot deal with this feeling, and they start to harm themselves, or they have a suicidal attempt, or they might have a suicidal attempt. And psychotic disorders, they're predominantly seen in adulthood, but they can also be seen in childhood. But early onset they have, and there might be a history in family, and generally they have negative symptoms, but when they in their first attacks, they might be seen as positive symptoms. And we can see a huge amount of anxiety, fear, and any child, if we see a child in fear, anxiety, it could be acute stress disorder or psychotic disorder, we have to we have to examine them for hallucination and delusions. So how are we going to approach? Generally, we need to provide a quiet environment. Empathetic and reassuring attitude is very important. So not only for the child and adolescent, and for the family as well. If it's the first time for a panic attack, we need to address the anxiety of the family as well. And because of the aforementioned reasons, we need to evaluate the patient holistically. And we have to have general medical conditions in mind and work with in collaboration with other branches, and suicidality should be questioned before expecting the child to talk about that. And what can we do in the emergency department? Psychoeducation is very important, so it might be the first thing. It might prevent the patients visiting the emergency ward over and over again. Because, for example, the family approach to the emergency ward with chest pain, and they think that it's a very big important problem, but discrimination of this is very important. Giving this message to the family is really important, but we need to validate that, not just as if we are not caring about that. So this supportive approach is very important in resolving the crisis, and there can be some breathing and relaxation exercises. They can be mentioned as the short interventions, and benzodiazepine can be used if it's necessary because the anxiety might be really high. And the most commonly used one, lorazepam, 0.5 or 2.5 milligram orally. And I'd like to add this, the cases coming to us with anxiety, when they are eliminated in our emergency ward, when we find out that there is no medical reason, if it's psychiatric cause, then we start SSRI there. Because starting this SSRI and taking this patient in the polyclinic follow-up is going to eliminate the patient to look for other medications like benzodiazepines, and also it's going to prevent them to go to the emergency department over and over again with no use. And then we see that they can handle these emotions. Thank you very much.